All right, that number is slowing down, and to respect everyone's time, I'll go ahead and get us started. So good afternoon or good morning, depending on where you're joining us from. And thank you for joining us today for Implementing Trauma-Informed Care, a case-based approach with Dr. Alissa Conklin. My name is Jordan Greenwald. I'm the Training and Community Engagement Manager at HCET, and I will be moderating today's webinar. First, I'd like to briefly introduce you to healthcare education and training. HCT's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCT is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please.
Sorry, 1 second. I need to stop my email
No worries.
from clicking, and I don't know how to do that. Otherwise, it's going to be very distracting.
If you just exit out of your email, it should.
I think I did it. And now share screen again. There we are. My apologies. Okay, and you can see, correct?
Yep, all good.
Okay.
All right, so this webinar does have closed captions available. To enable them on your screen, click Live Transcript at the bottom of your screen, then click Show Subtitle. You can then change the settings by clicking Subtitle Settings. Throughout the presentation, we encourage you to send your questions via the Q&A box. So to submit a question, you'll hover over the main screen, then select the Q&A icon at the bottom. Once selected, the Q&A box should appear on your screen. You can send a question anytime during the presentation, and we do ask that you send them during the Q&A rather than the chat. This just ensures that everyone in the webinar can view your question, and you also have the chance to send your question anonymously if you would like. Please be sure to follow us on our various social media accounts to keep up to date with the newest information and events. Now some quick housekeeping. So a link to complete an event evaluation will be sent to you after the event and after the conclusion of this training. Your feedback is greatly appreciated, so please fill that out for us. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please contact updates@hcet.org. Nursing contact hours are available for this. So in order to receive nursing contact hours, you must attend the entire webinar, return a completed participant evaluation / post test, and complete the nursing contact hour form and email to kbradford@hcet.org. No one with the ability to control content of this activity has a relevant financial relationship to disclose with an ineligible company.
Okay. Hi, my name is Kara Bergronick. I am the director of the Midwest Trauma Informed Care Training Center out of HCET, and I am delighted to welcome you again to this webinar as part of the MTITC webinar series. I want to just tell you briefly about MTITC as it is a new initiative for us. So in response to community need, HCET launched MTITC, making in-person and virtual training resources and technical assistance in trauma-informed care available to healthcare providers and human services providers across the Midwest. Our goal is to transform the landscape of health and human services by equipping professionals with the knowledge, skills, and support to provide trauma-informed care as standard practice to all. To learn more, or to partner with us or stay updated as we continue our rollout, please email updates@hcet.org. I also want to acknowledge and appreciate the funding for this webinar provided by the Indiana Department of Administration on behalf of the Indiana Family and Social Services Administration for Hoosier Families First Maternal Child Health Programming. And now, so this QR code will take you to our we have a sign-up page for MTITC to get all of our emails and outreach, and again, information about future events. So please, the QR code's the easiest. And then also if you need to reach me for any reason, my information is there. Okay. It is my absolute joy and pleasure to introduce my dear friend and the brilliant Dr. Alissa Conklin. Dr. Conklin is an assistant professor in obstetrics and gynecology at Indiana University. She is also the co-director of the Generalist Division, the medical director of the Coleman Clinic, and the medical director of the Indiana University Health Midwifery Service. Additionally, she is the co-chair of the Women's Health Task Force in Indiana Perinatal Quality Improvement Collaborative, IPQUIC, which is a statewide collaborative aimed at decreasing maternal morbidity and mortality throughout the state of Indiana. She and I co-run the subcommittee on trauma-informed care together, and she has been practicing trauma-informed care for more than 10 years, including the gentle or family-centered cesarean birth. She is amazing, and you are in for a treat. Take it over, Alissa.
Thank you for that amazing introduction. I really appreciate HCET asking me to speak on trauma-informed care today. And I appreciate all of you taking this time to join me in learning about this topic. Prior to joining academics, I was in private practice in Michigan for about 9 years. And as Jordan said, and as Kara said, I've been cultivating my practice on trauma-informed care for about 10 years now. These are our objectives for the webinar today. If you attended the webinar on January 10th about trauma-informed care in the reproductive and sexual health space, the first few slides here will be really familiar. So that I do that on purpose so that we can all approach this with the same background knowledge, because some people at this webinar might not have been at that one. I know we have a range of professions here, from primary care physicians, gynecologists, nurse practitioners, midwives, also medical assistants, nurses, non-medical staff, students, and others. And we all likely have a wide range of experience and exposure to trauma-informed care. While my professional focus is obstetrics and gynecology, I hope to speak broadly enough to show how trauma-informed care is important for all of us. I believe that knowledge is power, so we'll begin with some level setting so that we can all be on the same page with our knowledge by reviewing what trauma means, what experiences in life can cause impact in one's healthcare, and what trauma-informed care really is. This will be our guide throughout our talk that we'll reference back to, and we'll begin with what is trauma. Trauma can be defined in many ways, and spoiler alert, it's not just what most people think of when they think of trauma, like a car accident or leg injury. The Substance Abuse and Mental Health Services Administration, or SAMHSA, defines it as something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or even life-threatening, and that has lasting effects on the individual's functioning and well-being. Notice the 3 E's: events, experience, and effects. So looking at these 3 E's of events, experience, and effects, experience is key. It's the individual person who decides if a given experience is traumatic or not, and the same event that can be experienced by one person as traumatic may be just the opposite to another. A really good example in my world at OBGYN is the experience of a C-section. One person may truly prefer this type of delivery and feel empowered in that decision. Another person may find a C-section to be one of the most traumatically impactful experiences of their lives, perceived as a failure of their body or their goals or self-image. And they could be reactivated or even reminded of that trauma every time they look at their body in the mirror or every time they come to the gynecologist's office. Types of trauma can be broken down further into additional categories. Some trauma is acute, like a one-time sexual assault. Some is chronic or complex, like witnessing or experiencing domestic violence, loving someone with a substance use disorder, or living unhoused. Traumatic experiences can primarily affect one individual or extend to their family, like a severe illness. It can occur within the context of a group, such as trauma experienced by first responders or those who have seen military combat, or in a community as a whole, such as mass shootings in a synagogue or a queer bar. I want to spend just a few minutes on another very important type of trauma, historical trauma. Historical trauma reflects systematic oppression of a particular group across generations and disproportionately affects people of color. This could include genocide, slavery, police brutality, or forced relocation. Our patients and clients often bring well-earned historical mistrust of the healthcare system into our interactions with them. It's important to recognize that because this will be the lens through which patients impacted by this will view us in healthcare. For context, I'll share some pretty famous examples in the gynecology world. We'll start with J. Marion Sims. He was considered the father of gynecology and even had a statue erected in his honor in New York City, which has since been removed. Sims invented the speculum and developed surgical techniques that are still performed today, but he did this by experimenting on enslaved Black women without their consent. You may have seen this painting before. This shows Dr. Sims and Anarcha, who was an enslaved woman at just 17 years old when she had her first baby, and Dr. Sims performed 30 non-consensual surgeries on her. He did not use anesthesia, even though it had recently become available at the time. Back then, it was believed that Black women did not feel pain as much as white women, and in fact, that myth still persists today. It's well documented in the literature, even now, that Black people receive statistically less pain medication than white people do during hospitalizations and even after surgeries. This legacy of violence and historical and intergenerational trauma continues in our society, truly with more examples than we can count. From Henrietta Lacks, a Black woman who had her cells taken during cancer treatment in the 1950s without her knowledge or consent or compensation for use in medical research, the famous HeLa cell line that is still used today to create all kinds of medical breakthroughs, or the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told they were in a trial or about any of the potential risks involved, to our country's history of coerced sterilization, which was rampant even into the 70s. And then the Tuskegee experiments, where Black men were followed for 40 years from 1932 to 1972 without treatment to see the progression of syphilis without their consent well after treatment for syphilis was available. There are plenty of folks alive today who've either experienced these atrocities themselves or their children who grew up hearing about it. All of this has sown distrust in our system and in us. Systems level trauma and historical trauma enter our encounters every day in healthcare and in life. Keep these historical atrocities in mind as we move forward throughout this talk. So now that we have some understanding of the vast experiences that define trauma, let's look at something known as adverse childhood experiences, or ACEs, and the impact that ACEs also have on healthcare. Hopefully many of you have heard of the Adverse Childhood Experience, or ACE study, but if not, I'll briefly explain because this is truly the foundation for what trauma-informed care is. ACEs are traumatic events that occur in childhood. In 1998, Kaiser Permanente, along with the CDC, did a truly landmark study looking at 10 categories of childhood adversity that have been found to be particularly impactful on long-term health. The study focused on these experiences and found that they're linked to a cascade of adverse health outcomes, and that the more categories of ACEs a child has experienced, the more likely they are to experience those bad health outcomes. The participants in the study were largely white, largely middle class, and highly educated, so a second ACE study from Philadelphia focused on an urban and more diverse population and focused on community-level adversity and how that could impact health outcomes, and ultimately found these 5 additional ACEs noted here in the dark blue circles: living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and experiencing adverse neighborhood events. ACEs are incredibly common. From the original 10, 64% of people have at least one ACE, and 12.5% have 4 or more. In fact, before we move to the next slide and talk about the impact that ACEs have on healthcare, I would like all of you to take a moment to look at these 15 ACEs. What is your ACE score? You don't have to say it out loud, just take a minute to think about it. Maybe your ACE score is 0. If it is, I hope you can see how incredibly lucky you are. But I'm betting there are at least several folks on this talk today with high ACE scores. So with that in mind, what impact can ACEs have on someone's lifetime? Well, the more ACEs a person has experienced, the more likely they are to have any of these negative health outcomes. For example, people who've experienced 4 or more ACEs are 12 times more likely to have attempted suicide, 7 times more likely to be an alcoholic, and 10 times more likely to have injected street drugs. There was even a study showing that the more ACEs a person experienced, the more likely they were to refuse the COVID vaccine. So what impact does this have in our state? In Indiana, nearly half of Hoosier children have experienced at least one ACE. In fact, Hoosier youth have a higher prevalence than their peers nationally, and 8 out of 10 ACEs is measured by the National Survey of Children's Health. Also, 3 of the top causes of pregnancy-associated deaths are linked to higher ACE scores, including accidental overdose, which was the #1 cause of pregnancy-associated deaths in 2020. How common is this? Again, keeping in mind that 1 in 8 people has an ACE score of 4 or more, we likely all interact with several people each day who have a high ACE score, people who are carrying a history of adversity and trauma with them into their interactions with you. Why do people with more ACEs have worse health outcomes? ACEs actually cause sustained activation of the stress response system, which rewires the brain. This leads to what we all know as coping mechanisms, which are personalized strategies that allow people with a trauma history to function in their daily lives. Coping mechanisms appear dysfunctional or maladapted to an outsider, but they're perceived by the person using them to help facilitate their survival. Some examples of coping mechanisms we commonly see are self-medicating with illicit substances, reclaiming sexuality, dissociation, and even self-harm. Okay, so now that we have a good foundation of what trauma is, what ACEs are, and the impact that these can have on our health, let's talk about what we can do about it. Let's dive into trauma-informed care. Trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health. It is inherently patient-centered. A trauma-informed framework assumes that everyone has a trauma history and that medical evaluation and treatment themselves are potentially traumatizing. It acknowledges that a patient's life experiences will impact their perspective when engaging in the healthcare system, and that awareness of these perspectives has the potential to improve patient engagement, treatment adherence, and health outcomes. Trauma-informed care is not the same as providing trauma-specific services, such as treating that broken leg or the sequelae of that car accident. And importantly, disclosure of past traumas is not necessary to provide trauma-informed care. Rather, the foundation of trauma-informed care is the assumption that all people carry past traumas and that all people benefit from this type of approach. We utilize the 4 R's created by SAMHSA, which states that a trauma-informed approach is one that realizes the widespread impact of trauma, recognizes the signs and symptoms of trauma in clients, families, and staff, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. This 3-minute video is a great introduction to trauma-informed care and the impact that ACEs can have on a person's lifetime, as well as a brief overview of what we can do to implement a trauma-informed care approach. It introduces what is really the key paradigm shift of trauma-informed care, shifting your thinking from what is wrong with you to what happened to you. So I'll play this video.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made, plus our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Good video. Okay, now that we have some background on trauma and ACEs, as well as a basic foundation for what trauma-informed care is, let's dive into some cases and see how we can apply this. Before we get into this, I really want to encourage all of you to think about these patients and their stories as a patient yourself. Yes, most of us are healthcare providers or involved in healthcare in some capacity with our work, but we are all also patients. Try to take a minute to bring to the surface in your mind interactions you have had as a patient, both good and uplifting interactions, and also those that were maybe not so great or encounters that maybe made you feel like just a number. Try to think what made those great encounters so good, and also what about those maybe not so great encounters made them feel unpleasant. Okay, so let's dive in with our first case. We have a 31-year-old lady with a history of anxiety, depression, and white coat hypertension coming into the office today for an annual exam, and it's her first time here. Her surgical history shows she had a laparotomy in the past after a car accident that resulted in a bowel resection. Her social history shows that she works as an ICU nurse since about 2019. She's divorced, she smokes half a pack a day, but she denies illicit drug use. And her mom died of breast cancer pretty young, and her dad has a history of alcoholism. Now, I'm giving you all the juicy details here on this patient. For the case presentations, we'll spend most of the time on this particular case because it covers a lot of important points. But going forward, I won't give away all the potentially impactful history because remember, we are not owed a disclosure of anyone's trauma history. The whole concept of trauma-informed care is to use it as a universal precautions model, similar to how we think about bloodborne pathogens. We don't wait for test results to return when we're examining patients. We put our gloves on for everyone. Just like gloves, trauma-informed care should be applied to everyone. So back to our 31-year-old patient. What clues have been revealed in her history that she may be carrying trauma with her? You can raise your hand and we'll take you off mute if you're willing to shout it out. Any clues that you see, or you can type it in the chat. And we'll just take a minute to see if people have some thoughts. And then Jordan, I don't know if you can, I can't see the chat. So Jordan, are you able to see it?
Yep, I can read it out for you as folks put things in.
Yeah. Anybody think of any trauma history that they might have?
Folks are saying mom has cancer history, car accident, secondary trauma from ICU experiences, ICU nurse, father's alcoholic, mother's death at a young age, and early death of mother and father's an alcoholic.
You guys are nailing it. She has anxiety and depression. Is that because she has a lot of stuff she's dealing with, like a trauma history? We don't know. When I see people who have a history of quote unquote white coat hypertension, I always wonder if that's because their body is stressed out by being in our space for some reason. Surgical trauma for sure, right? She got in this car accident. She had to have a laparotomy. She had to have a bowel resection. I'm sure there was a time in there where she didn't know how things were going to turn out. She's divorced. Is that a great thing for her? Was that a traumatic thing for her? We don't know. Mom definitely died at a young age. At 44, she was also probably pretty young when her mom died. That's very traumatic. Dad struggles with alcoholism. Is that a coping mechanism for him? Is there something he's dealing with? And work stress. This is a real source of trauma, as some of us are well aware. I mean, in her case, think about it. She started as an ICU nurse right before COVID hit. How hard must that have been for her? I mean, what kind of things has she seen? And we had shortages in healthcare providers, and some were dying before the vaccine came out. I can't imagine what kind of impact that must have had on her. And notice her potential coping mechanism, smoking. It's important to remember, again, that people aren't always aware or conscious that these activities are coping mechanisms. Now, what clues in her history may point to a higher ACE score? This one's a little harder. And again, remember, no one owes us a disclosure of these past experiences, but feel free to, again, raise your hand and we'll take you off mute, or type in the chat anything in her history you think might represent an ACE score.
We see divorce, alcohol abuse, death of mother, dad's alcoholism.
Kind of
Father's
similar things. Yeah.
Yep,
Kind of similar
similar
things.
things.
We know for sure dad has or had a substance abuse history. We don't actually know if he's currently using alcohol or if that's an issue for this patient at all. But what other impact might that have had on her childhood? Could he have a mental illness and he's using that as a coping mechanism? Maybe there was abuse in the family. Maybe her parents are divorced. We don't really know. And just remember, without a voluntary disclosure, we'll never know these things. And no one owes us a disclosure of their histories. Okay, this picture might only be funny for those of us above age 40, but let's rewind a second and say, what if this was all you were given on that patient? that she's a 31-year-old on Zoloft for depression, here to establish care. Does it change your perspective on her? Does it change how you perceive your visit's going to go with her today? It's easy to ignore a person's past experiences and how that may factor into your visit when we're so rushed to get to the next patient and just get through our day. But when we adopt a universal precautions model with trauma-informed care, just like putting on those gloves for an exam, it won't matter if you gather all their traumatic past history or whether or not you know their ACE score, because you will assume that everyone has a traumatic history and a high ACE score. I'm hoping through this webinar, you'll be able to gather some tools to start modifying your interactions with patients to incorporate this without adding any more time to your visits. Okay, so now that you have her history, let's dive into this encounter. Remember, think about it as if you are a patient. What does the patient think about before they come to the office? Before they meet the provider? While they're waiting to be examined? How many times have you gone into a new provider's office and wondered any of these things? And what can be done to alleviate these fears? So many things. A clinical experience where the entire clinic practices trauma-informed care starts when the patient walks into your physical space and continues throughout their visit with everyone with whom they interact, and even after their visit and their understanding of their care plan. So let's get into details on how we can do this. What does your waiting room look like? Is it cramped? Is there music? Any visually pleasant pictures or paintings? Any educational material? And then there's your front office staff. They represent your entire practice and you as a provider. How do they interact with the patient? Do they act neutral and like they're just trying to get through their day and check their boxes? Or do they see the person in front of them? Do they smile? Are they welcoming? What do they say to the patient? Do they reveal anything personal about the patient in front of others in the waiting room? Is there anything in your waiting room that signals to the patient that this office is a safe space? What does that even mean? There are graphics you can display that underscore a team approach to healthcare, that the patient is the most important person in this office, and that their voice matters. This can be very affirming to someone with a traumatic past or a high ACE score. Do you care for LGBTQ patients? What about rainbow or trans flags to signal that your clinic is a safe space for these folks? And speaking of affirming, when a patient walks up to the front office staff, how do they get the patient's name? What's in a name? What about a transgendered patient whose legal name is what's in their record and associated with their insurance, but not their actual name? Do you have any idea how traumatizing it can be to be dead named in a clinic waiting room, surrounded by people, when your legal name signals the opposite gender and people stare at you? Not to mention that for some trans folks, just hearing that dead name can be re-traumatizing. And it's easy to do, right? It's easy to just hide behind a crappy EHR and the fact that the system maybe requires the legal name to be listed. But these are micro and sometimes macro aggressions that can create a fractured experience in the healthcare system. And for people who are already marginalized and who often already carry past traumas with them, it can be a huge deal. Look at these pictures. This first one, no signage, no signal that it's safe for a trans patient, and not a particularly warm or welcoming staff. And then look at this one. Can you see the difference? I mean, you can actually feel the difference, right? All of these things can either set this patient up for a great and affirming visit or really negatively impact their experience with your care, even if you are awesome. Are there options at your front desk for a patient to either state their name or provide their ID without saying a word? This is an easy way to provide stress relief to any person who does not want to speak their legal name out loud. You can even put a sign in the waiting room that states these options so that someone waiting in line to check in can understand what their options are and maybe get a little stress relief before they've even spoken a word. Notice on that bottom photo, the sign that's off to the right. It's hard to read, so I'll enlarge it for you here. It lets the patients know, one, what is expected of them at check-in, and two, that they have choices to provide that information. And that little graphic on the left side of the bottom photo, again, it's hard to read, so I'll enlarge it. This is one of those graphics that underscores a team approach to healthcare, that the patient is the most important person in the office, and that their voice matters. Another encounter that can make or break a patient's experience with us in healthcare is the medical assistant or LPN who calls the patient from the waiting room, walks them to the exam room, and gets their vitals. How do they call the patient? Are they using Mr., Miss, Mrs., and last name? Pitfalls with that would include non-binary folks. Even people recently divorced may cringe at hearing the term Mrs. Do they call the legal name in the chart? What if that is a dead name for a transgender patient like we reviewed before? It's important to check for their preferred name. And once the patient walks back, is there small talk of any kind, like, how have you been today? Or did you have trouble finding us? Or is it just awkward silence? Setting some verbiage here for a few routine statements can be really helpful. Again, think about times when you have been the patient, when you have been called from the waiting room, when you felt welcomed, calm, and peaceful. What were those interactions like? On the contrary, when you felt that things were impersonal and as though they were just trying to get their part of your visit over with, what was that like? If you work in healthcare in any capacity, You have at least some power, and I would even argue that you have the responsibility to help make a patient's visit in your space uplifting and empowering. Does your MA or LPN ask the patient to get undressed before you even meet them? In some clinic spaces, meeting a patient dressed is a luxury and just not feasible. And in that setting, there are certainly good ways and bad ways to keep the clinic flowing. A good way here would be to have verbiage the MA says that specifies why the patient is being asked to undress first, what the exams are the provider may want to perform, and asking the patient if they have any questions about that, and then stepping out of the room. Another one is to let the patient know the provider will knock before they come in. This can be reassuring to a nervous patient who fears someone may barge in while they're in the middle of getting undressed. And I know that seems silly, especially if we're about to do a full physical exam, but to some patients, they really need to feel that control, that they'll be given the opportunity to hide their underwear in the folds of their clothes and be seated on the exam table before the provider walks in. If you have the luxury in your clinic of meeting the patient before they get undressed, consider doing that. No one feels the most empowered in a gown and sheet. Most people don't want to share the concerns with no underwear on. Another opportunity for either creating fear or helping to calm someone is the room itself. What does the room look like? What items or instruments are out for them to see? Sometimes having certain items out can cause stress to a patient, even if the instruments are out all the time and only used when needed. For example, if you're a pregnant patient coming in for your routine OB visit and you walk in the room and you see this, a gown and sheet on the examining table, and this, a speculum and swabs out as well, what are you thinking is going to happen to you today? You're thinking you're going to be asked to get undressed, right? Even if we as the providers know they are not going to need an undressed exam that visit, the patient may be experiencing unnecessary stress simply because of what they see. This is our clinic, and we make a point to only set out the gown and sheet when we know the patient will be getting undressed, but the instruments you see here on that table are always out. This is for ease of use of the provider, but for the patient, you can see how it could be a source of unnecessary stress. So maybe it's best to have routine where you let them know at their very first visit, these instruments are routinely out, but they will only be used when needed. Do you have any educational material on the walls for them to look at while they're waiting? Any artwork or something calming or peaceful to look at? I guarantee you patients are looking all around that room while no one else is in there. What do they see? Do you have anything on the ceiling for them to look at when they have to lie back for an exam? Something like this? These are light covers we have in our exam rooms, just a little something to distract patients during their exam. Distraction is actually a fantastic method for pain relief and honestly could probably be its own talk, but visual distraction can be helpful when trying not to focus on parts of an exam. Usually in the flow of outpatient care in the office, the next thing that happens after a patient is called in from the waiting room is taking their vitals. For most, this often involves getting on a scale. In fact, it seems most offices have a blanket policy about weighing all patients. As a patient, I have personally only been to one office in my life that didn't require my weight. All the others have walked me down the hall, straight to the scale, and said something like, "We'll stop at the scale so we can get your weight." I would like to push back on this and ask you all, do you really need every patient's weight at every visit? As a gynecologist, I can say no. We actually rarely need someone's weight for their care. There are certainly instances in which we do, such as prescribing the patch, which is considered less effective when they weigh over 197 pounds, or in the instance of weight-based medications like methotrexate. But with most of our visits, the weight of a patient actually doesn't play into their care. This is, of course, not true with weight management-based visits, but I am speaking about overall care. Even as an obstetrician, where it's standard to weigh every patient at every prenatal visit, do we really need to do that? After all, it's total weight gain in pregnancy we monitor and counsel on, not particularly weight at each visit. And then there are the health system requirements. What do your systems require for vitals? Do you know? In my health system, it's 3 vital signs, just 3, but they can be any of the vital signs like heart rate, blood pressure, pulse ox, etc. We actually don't have to get a patient's weight at every visit. I would encourage you all to think about this too. Here's a tiny sign next to a scale and the MA explaining to the patient they don't have to be weighed today unless they want to. It's hard to see, so I'll enlarge it here. Why does this matter? Why should a patient care if we weigh them or not? Think about someone with a history of an eating disorder. It can be re-traumatizing to have to see their weight. Or what about the average person who just would like to lose a few pounds and maybe doesn't want the reminder today? What about you? Again, think about when you are the patient. Have you ever gone to a provider's visit, been asked to get on the scale and thought to yourself, geez, I just wish I didn't have to do this today? In fact, research shows that patients are less likely to seek out care if they know they will have to be weighed. Some people counter argue to this that if the patient doesn't want to be weighed, they should just say so. But that makes a lot of assumptions about that patient, that they've never had their voice taken away from them, that they have the agency to speak up and the confidence to do so. Many have a fear that if they speak up, they may be negatively judged or that that judgment may impact their care. So consider having signs out that demonstrate this. like that sign by the scale, or even something like this, a post someone shared on the platform formerly known as Twitter last year, and it was featured on the Today Show, where she went to her annual exam, and in that office, she noticed these cards sitting at the check-in counter. In that office, anyone who didn't want to get weighed could just take this card, hand it to the MA, and never have to say a word. She said, "I felt really seen and validated and grateful." At the time of that article, she had 27,000 likes and 3,600 retweets, or whatever they're called now. Something like that gives voice to people who truly may feel voiceless in our spaces. And then the blood pressure. Does the MA explain why we need blood pressure? Is it done right as soon as they sit down or at the end of the visit? Is the patient offered a choice about that, or offered a choice as to which arm they prefer? In many instances, a simple choice that may seem meaningless to us can really help the patient feel empowered and in control, and can be so helpful in how they perceive their healthcare experience. And all of what has happened before this moment is going to set the stage for how this patient perceives the healthcare provider before they even walk in. So now the provider is in the room. Do you knock before you walk in? Do you ask for permission to enter? I know it seems silly, but I view the exam room as the patient's space. I knock, I crack the door slightly, I introduce myself, and I ask for permission to come in. It's a simple way to let the patient know I am there for them and not the other way around. Once you sit down, how do you get the conversation going? Do you ask the patient a question like, "It looks like you're here for an annual exam, is that correct?" Be intentional about how you begin. And for those of you on this webinar today who are providers, how long do you think you let the patient speak before you start talking? This has actually been studied, and on average, the patient gets to speak for just 11 seconds before we interrupt them. Sometimes it's for a good reason, like getting clarification, but oftentimes it's because the provider feels that they know where this is headed and tries to steer the conversation. This can feel very violating to patients, especially those with a history of verbal, emotional, or psychological abuse. Most of us in healthcare have big type A go-getter personalities, and we can very easily intimidate someone who maybe has had to make a massive personal effort just to leave their house, let alone speak about something that makes them feel vulnerable. When it's time to do the exam, how do you start that? Do you explain to the patient first exactly what you recommend? Do you wait for either verbal or visual confirmation that the patient consents to that? Or do you just dive in and assume the patient knows why they're here? Again, be intentional. Assume all patients have a trauma history. Use the universal precautions model of trauma-informed care, and realize that all patients will benefit from explaining every step. Also, what about learners? Many of us have learners with us in clinic. Trauma-informed care, like all healthcare, is a practice, and like with all practices, we should always strive to be better. A patient recently taught me that I need to be more intentional when learners are in the patient space. When she was getting an annual exam, and the student and I knew that only I was going to examine her while the student observed, but I hadn't specifically told the patient that, because I made an assumption that she knew because she consented to the student being in the room. So before the exam began, she pushed her body back a bit in defense, and she said, wait, who's going to touch me? That was a light bulb moment for me, that when I have learners with me, I need to do better explaining when only I will be touching the patient, and to never assume consent. When you're ready to begin the exam, how do you approach that? Explaining every step just prior to doing it can help ease fears that the patient may have about what's going to happen next. Again, emphasizing that trauma-informed care is a practice, and once you make a commitment that you want to provide this type of care, you're always practicing to improve. I'll share another recent modification that I've made. When examining the thyroid, I fully admit I used to examine it from behind, like this picture. This past year, I had a medical student actually point out to me that although I practice trauma-informed care, my thyroid exam is not particularly trauma-informed, and those were her exact words. And you know what? She was right. I mean, look at this picture. While I always explained to the patient what I was going to do, I would show them with my hands. If a patient has been strangled before, can you imagine how activating this would be? Change is always hard for us in healthcare. We're pretty set in our ways, but after a few weeks of my own discomfort trying that exam from the front, I now comfortably perform a thyroid exam from the front like this. The heart and lungs are similar. We can expose the patient entirely or just expose what we need for that part of the exam. We can even ask the patient, like in this picture, if they could lift their own shirt or gown for us to examine them. That gives power back to the patient to control just how much they expose, even if that means we have to ask them to lift it a little higher. The abdominal exam is similar in that you can focus on only exposing the area you need, explaining to the patient that you will be using just your hands and some pressure, and then exposing that area. Or you can have the patient lift their own shirt or their gown for that portion of the exam like this. After you've done your exam, what do you do next? Do you summarize your findings and care plan recommendation while the patient is undressed? Do you step out so they can get dressed and then you go back in? Do you have your MA go in and close up the visit for you? None of these are wrong. Obviously, it would be ideal for the patient to be undressed for the shortest time possible. But again, sometimes our clinic flows just don't allow that. So be intentional with how your visits are closed up and try to think about what you would want as a patient. Do you give written information to patients before they leave, like a written summary of your care plan or generalized education about their topic of concern? All these things can help the patient feel more heard and to help clear up any potential misunderstandings the patient may have had, but didn't mention to you during the visit. This happens sometimes for a variety of reasons, some of which include the patient feeling embarrassed or ashamed that they didn't really get what we're saying during the visit. So written information can help them have time on their own to digest it at home. Here are some pictures of various educational dot phrases I share with patients. In REHR, I can simply type dot dysmenorrhea or dot infertility, and boom, all of this text shows up in their after visit summary. So now let's move on to our second case, the breast and pelvic exam. These are way more intimate in nature than just a routine listening to the heart and lungs, right? Whether you want it to be or not, there is such vulnerability here. I mean, think about it. Patients are undressed, they're in a terribly vulnerable position, and most of the time their genitals are exposed. And I don't know anyone who feels they're most empowered when they are undressed, lying down in front of a stranger with their genitals exposed, except maybe Chrissy Teigen, here, who is rocking a paper gown as she documents her annual GYN visit on her social media account. Okay, so this patient is a 42-year-old para 2 who presents for her annual GYN exam. She's a new patient to you. You review her history. She has no medical problems and no surgeries. She's had 2 babies vaginally, both uncomplicated. She's never had an abnormal pap smear, though her last one was 10 years ago, and she was recently diagnosed with herpes. She's divorced, denied smoking, drinking, or illicit substances, and she works as a paralegal. She denies any significant family history. There isn't much there that appears traumatic, right? Well, to you anyway. However, you get the sense in the room that she seems nervous. Overly nervous, you think, for someone who's had 2 deliveries and appears to have had at least some GYN care in the past. So you have her history. Are there any clues in her story that might point to any ACEs? I'll just jump in and say none, which really means she may have some, you just don't know about them. And what clues may point to a trauma history? Again, I'll jump in and just say she's divorced. She got diagnosed with herpes last year. Are they related? It's possible. Was there cheating involved? You just don't know. And of course, I assume in the legal world, there's work stress too, just like in our world. How impactful any of these may be on her visit today, you just don't know. This is why the universal precautions model for trauma-informed care is so important. You have no idea what people are hiding behind their own curtains. So let's say she reveals to you that her husband did in fact cheat on her. He was physically and emotionally abusive. He gave her herpes, and she's reminded of this by being here today. Now, I'll tell you, most patients do not feel they have the agency, the strength, or the power to say something so vulnerable. So even if she told you none of these things, trauma-informed care using its universal precautions model will help her feel more safe and more empowered during her visit. So on to the exam. How do you expose the breasts for examination? Is the patient's chest exposed the entire time, or do you just expose one breast at a time? There are options for this as well. Do you have a cloth gown or paper gown in your clinic? Do you have them open in the front or the back? Paper gowns kind of suck because they often rip. They're usually one size fits all, which means it really doesn't fit all. And so it can be very othering to bigger patients, and they're cold. The patient could keep their shirt and bra on, and you could just ask them to lift both for the exam if that helps them. Also, there are some unique gowns out there called dignity gowns as an option, where there's a small pocket space, like in this picture, that allows the clinician to reach in for the exam but never expose it visually. While this prevents visual inspection of the breast and chest skin, it is an option for those who do not want to be exposed. These options can be helpful for those with a trauma history. If you choose to offer choices to the patient, the most common complaint I often get from clinician is, I don't have time to offer all these choices and ask what they want. This is where you can utilize your resources. Ask your MA to have this conversation with the patient, and then when they present the patient to you, they already know what the patient prefers. When it comes for the pelvic exam, every patient's favorite part of their annual gyne visit, there are a lot of opportunities to help the patient feel more comfortable. For example, the head of the bed. Is it flat all the way? Is it more upright? Most patients do not feel safe, or they feel too vulnerable having the exam table completely flat like this. Consider raising it up a bit like this. This also facilitates the patient being able to see the provider a bit during the pelvic exam, which can really feel more empowering, and it really doesn't alter our ability to perform the exam. And when it comes to actually performing the pelvic, how do you position the patient? Do you always use stirrups like in these photos, leg rests, the extension at the bottom of the table? Many providers use stirrups, but stirrups are pretty restrictive. They only allow the patient's feet to be in one position, and the patient can't choose where they want to put their feet. Many examining tables have the extension at the foot of the table that pulls out, and for most, this is actually adequate space for a speculum. One of the reasons I hear that providers are resistant to using the extension instead of the stirrups is that they don't feel like the speculum can be adequately placed But for most, this just isn't true. Like in these pics where this lovely lady is demonstrating for us just how much room you actually do have when using the table extension and a speculum. The benefit of using the table extension is that the patient can actually choose where they want to put their feet. And as a bonus, if I need to put items down like the pap supplies or whatever, I can use it as a table. Not all clinics can do this, so if you have to use stirrups, you can certainly check in with the patient before beginning the exam and ask if their hips are okay with the stirrups in that position or if they need any adjustments before you begin. And some patients, particularly older ones, actually prefer stirrups. That's okay, it's about choices. Another source of comfort or discomfort is temperature. If you have the ability to have gel warmers, that can be really beneficial to patients as the cold gel can make people feel more tense, which does not help. In our clinic, we also offer heat packs that the patient can utilize during any procedure as a form of distraction. And speaking of distraction, I actually encourage patients to listen to music or scroll on their phone if they want some distraction. Some love this, others don't need it. There's actually quite a bit of data supporting music, games, or scrolling as an effective pain management strategy. Basically, anything with cognitive engagement and interest to the patient can work. Again, it's about choices. And I would be remiss if I didn't talk about transgendered non-binary care in this space. Transgendered folks still need regular care, but for some, this care can be traumatizing. Choices are really great here, like an exam under anesthesia in the OR or conscious sedation, or even just topical numbing cream. We have this great compounded numbing cream in our clinic that works miraculously for topical analgesia. And for some, we can even complete procedures without injections using just this. While caring for transgendered patients could be honestly a whole series of talks on their own, it's important to offer choices to the patient, to care without judgment and listen to their fears and also what they feel will work best for them in this setting. Remember that while you are the expert in medicine, the patient is the expert in their own life. Make sure they know that their input on their care is just as valuable as yours. When caring for trans patients, I also recommend asking them what they call their parts and using those terms. Okay, moving on to our third case, getting blood drawn. Maybe in your clinic space, you have a phlebotomist, maybe you don't, but as we all know, because we have all likely been a patient needing to get our own blood drawn, this is a common necessity in healthcare and also a common source of pain. So we have a 21-year-old G1, meaning her first pregnancy, and she is 10 weeks pregnant, presenting for her first OB visit. Her history is pretty insignificant. You provide prenatal care. If you provide prenatal care, you know that the first visit can be really, really long. They get an ultrasound for 30 to 45 minutes. They see a provider for 30 to 45 minutes, including their wait time. And in our clinic, they get education from our nursing staff, which also takes some time. Then when it's all done, they have to get their blood drawn. It's a minimum of 2 to 3 hours. And if you've ever been pregnant before, think about that first trimester. How did you feel? Many people have nausea, they have trouble eating, they're uncomfortable for all kinds of reasons. And this can make them more prone to feeling bad during a blood draw. So any clues to her history as to having any adverse childhood experiences? No, right? At least none that you know of. Any clues to trauma? Also nope. Same, maybe she does, maybe she doesn't, but we don't know. As with all patients, when someone is getting their blood drawn, we should all approach them with the universal precautions model. This ensures that anyone with a trauma history will have safe, calm, and potentially empowering care. And you're probably thinking, it's just getting your blood drawn, who cares? But for people with a history of IV drug use and remission, people with pain sensitivities, anyone with an abuse history who has ever been held down or trapped in any way, seeing this chair and getting blood drawn can reactivate those feelings of helplessness. While blood draws are generally pretty quick, this is a great place for 2 important tools that can help someone get through it more easily. The first is choices. Do they have a preferred arm, a preferred vein, or an area on that arm? Or having routine verbiage you ask everyone, such as, do you have any concerns you want to share with me? This gives everyone an opportunity to say things like, I'm a hard stick, or I have a fear of needles, and then gives the phlebotomist an opportunity to address or alleviate these concerns. The second is distraction. Same as during exams or procedures, offer for the patient to scroll on their phone or listen to music. As stated previously, distraction has been shown to help decrease the pain experience. Even visual distraction can help. So in preparing for this talk, I actually sat down in that chair to see what patients see when they sit there. And you know what I saw? This, nothing on that wall, nothing to help with visual distraction. So you know what is arriving this week? This. I just want something to help them be able to get themselves through this visit and that blood draw with the least amount of pain possible. There's really unique opportunities in blood care and blood drawing as well to help alleviate pain, such as this. This is called Buzzy, which is cold and vibrates. You just put it on the arm above where you're going to be drawing their blood, and it distracts them from the needle insertion pain. And speaking of pain relief, what about any topical anesthetics like lidocaine gel or the Dermoplast spray that we commonly give out after deliveries for the perineum? This has benzocaine in it. Maybe just 30 seconds of one of these could help so much with needle pain. These are easy and quick opportunities to universally help all patients have a better experience when getting their blood drawn without adding much time to the encounter. Okay, moving on to our last case of the day, a radiology experience getting a mammogram. We have a 40-year-old coming in for their first mammogram. As usual, they have no obvious signs of trauma history or ACEs, or at least none that you are privy to. But this brings up a number of areas where care can be fractured or produce fear for a patient, which also means these are opportunities to practice the universal precautions model with trauma-informed care. Every patient, when it's their first time doing anything, will have many of these questions. Where do they go? What instructions are given for their body care on the day of the mammogram? How and where do they change? What is the waiting area like? Is it public, where they wait with many other patients, or private, where they wait alone? These experiences matter, which points out that asking for patient feedback can sometimes be the greatest teacher. I often say that patients have taught me more how to care for them than I ever learned in medical school. If we ask for feedback and we listen, we can truly improve their care. So if you've never gotten a mammogram, it takes your boob in between these plates like this and smushes it down to a level of insanity that I don't think any of us would have thought possible, much worse than this sweet little photo tries to pretend. It's not at all comfortable physically, though I personally don't think it's terrible. Every patient is wearing a gown open in the front, and the mammogram tech has to get really close. Then you have to walk completely up to the machine. The tech literally stuffs your breast into the machine like this, and you are often so pressed into the machine that you have to hold on to it like this. You'll notice in these pics that the patients are pretty exposed. In the one on the left, the patient has their gown half off. This is pretty common, as the technician really does need to get your entire breast tissue into the machine. Then it squeezes, and just when you think it couldn't possibly flatten your breast any further, it squeezes even more. It's quite something. And then the machine moves, as you can see the difference in these two pics. So they have to squeeze it over and over again. They also often ask you to hold your breath during certain compressions, so it can feel really strange. And for some, it can feel like they are trapped, which can be triggering. This experience produces many opportunities to provide the universal precautions model of trauma-informed care. What gown colors are offered? I have seen several trans and non-binary patients tell me that they hate that the mammogram area near our clinic only offered pink. Can color choices be offered? I know it seems silly, but it is a microaggression against someone who associates the pink color with something negative. So in our space, we talked with the mammogram suite, and guess what? They now offer color choices. Are there offerings in the waiting room, like magazines to read or a TV to distract them? Any snacks or drinks? These are pics of the mammogram waiting area near our clinic. You'll notice the water and the tea options, the TV, the magazines, and there's even a fish tank. These can help calm someone and ease their waiting time. Once they're called back to the actual machine, what happens? How does the tech interact with the patient? Do they see the patient in front of them or just the next patient on their schedule? Again, with trans men who haven't had chest surgery yet, they may not want to hear the word breast. So is there a protocol where the patient is asked what word they want used? It seems small, but this is very important to a trans patient and helps them feel safe and seen. And during the mammogram itself, there are ample opportunities to check in frequently to ensure that the patient is doing okay, or if they need to pause, maybe for a few extra breaths before the next go round. Okay, that's all the time we have for today to discuss cases and how to apply trauma-informed care, though we will continue these webinar series in the months to come. But I wanted to go ahead and summarize with some quick pro tips and take-home points. In any office space, trauma-informed care starts with the waiting room and the reception staff. It's so important to have a welcoming place for all, including signs to signal a safe space for those who are looking for those signs, including options for providing their legal name. Come up with verbiage you or MA or LPN can use when bringing a patient back from the waiting room, taking their vitals and taking their history. Remember, as a provider, your MA represents you. What do you want your patients to hear? Consider options regarding the scale. Maybe you can offer to patients in your workspace to not be weighed unless absolutely necessary. Be aware of how your attention is perceived. If you use a computer or take notes in the room, just be intentional with how you utilize that. Explain all recommended exams in detail so the patient knows what to expect. Offer distraction techniques such as pain relief when able, visual and audio distractions, and the most common source is the patient's own phone. Encourage them to use it if it helps them get through the visit. Check in frequently with them. A simple, "Are you doing okay?" or "Do you need a pause?" during a procedure or an exam can be empowering to the patient as it presents them with choices. And that brings us to the last pro tip, choices. Even when they seem simple or silly to you, offering choices whenever you can at any step can really help the patient feel more control and feel more safe. Remember that you should never feel that you are good enough in practicing healthcare. While you're the expert in medicine, the patient is the expert in their own life. We should all strive to always be looking for ways to make our interactions in healthcare feel more safe, more welcoming, and more empowering for our patients. That's the end. Any questions? Happy to take them.
Thank you so much, Dr. Conklin. I'm not seeing any questions in the Q&A at the moment, but folks definitely feel free to put your questions in there, or if you would prefer to ask your question verbally, you can use the raise hand feature and I will unmute you.
It looks like there were some comments in the chat. One person said, thank you for highlighting LGBTQIA patients in trauma-informed care. And that truly, that could be a whole series of talks on its own, which I would love to participate in. Somebody said these options are amazing. Your office gives so much more power and control back to the patient. So empowering. It's a constant process, right? Like I've been practicing trauma-informed care for 10 years and I'm not done. Like there's still so many more modifications I want to make in my clinic space. Patients are constantly teaching me how to do better with them. Even like I mentioned, the medical student pointed out to me, it's just constantly being aware that you're always trying to do better. Other people said this is very helpful and they enjoyed the case presentations. I'm happy to always present more, or if there's certain topics or niches or avenues in clinic spaces or inpatient spaces people would like to hear more about, happy to participate. One person asked, do you have any thoughts on using the ACE questionnaire for screening in a clinic setting? I think this is an amazing and awesome idea to do both trauma history and ACEs. It's just important to always be cognizant of what you're going to do with that information. So if you have the ability to then react and act to provide them with, care of counseling, do they need to see a psychiatrist? Do they want to talk about it? That's an important one. Like in our questionnaire, our old history form, it asked them if they had a history of abuse or sexual assault, but never asked them if they want to talk about it. So some patients would choose to mark no, because they don't want to speak about it. So just be cognizant of how you're going to utilize that information and what you're going to provide to the patient in response to that. One person asked, yes, outdated waiting areas are an excellent place to start. And honestly, just walk around and sit as a patient. Like I've been here for 2.5 years. I never sat in that phlebotomy chair. I sat in it and realized, wow, that is a blank wall. We should do something about that. So I went out to the waiting room and sat out there to see what it's like for patients too. Somebody said, do you feel that you will have some providers that are resistant to or not receptive to taking the extra time to incorporate trauma-informed techniques? I'm here to tell you it does not take more time. At first, it's a little bit of change, which is hard and feels more time consuming. But once you incorporate it into your daily life, it does not take more time. So I think people are resistant because they fear it will take more time, but it truly does not. You just have to find ways to utilize your resources, like having your MA help you. For example, when you're offering choices to patients, have your MA do that for you while you're seeing the other patient ahead of that patient. So you can definitely do this without making your life worse.
Dr. Conklin, as we wait for more comments and questions to come in, do you mind moving to the slide that shows upcoming events?
Absolutely.
People are thinking about that. Awesome. So we have a series of additional webinars coming up through the Midwest Trauma-Informed Training Center. On March 12th, we're going to have a mind-body medicine talk where we're really going to talk about ways to stay regulated in the face of caring for someone who is activated or working with someone who is activated. Also, those are going to be techniques that you can use to help teach your patients, right? Or teach your coworkers, right? What are some skills-based ideas that we can utilize? And then Dr. Conklin will be back with us in April for kind of round 2 of a case-based approach because today was so stellar. I also want to highlight that in February, we have 3 upcoming dates for some listening and learning sessions. Again, MTITC is a relatively new initiative for us, and we are really looking for your feedback to tell us, what do you need from us? What do you want from us? How can we amplify and strengthen the amazing things that you're doing? How can we help reduce barriers? What is your dream of how we could serve you? And we would just, again, love to hear all of your thoughts. So one of those is a morning time, one's a lunchtime, and one's an evening time. Many of you may have gotten that sign up already if you're on our listserv already. If not, again, use that QR code to join our listserv. And we will be sending that information to folks who attended today. So again, we would love to see you there. Anything else, Jordan, in the Q&A?
I'm not seeing anything in the Q&A, but I'm gonna go ahead and put the evaluation link in the chat. This will also be sent via email, but if you could please fill that out, that would be much appreciated. Helps us inform future events. And I will also be sending out the nursing contact hour form via email as well if you're seeking nursing contact hours.
With the question about screening with the ACEs questionnaire, that's such an interesting question, right? Because it was designed for like population level screening, not so much as an individual screener. So it definitely can be utilized. And I loved Alyssa's comments about like, you just have to figure out what you're doing with it. So some places like California has like implemented routine ACEs screening across the board, which I don't necessarily think was how, actually not, I don't think, I know was not how the original creators of the ACEs questionnaire intended it to be used, but there is some interesting data out of California. So there's different things to look at with that.
There was a comment as well in the chat. Isn't there an ACEs training?
So Ashley, I'm not sure so there's many ACEs trainings. We could certainly do one more specifically on ACEs. And there's many that you can find virtually. We probably, I don't know, Jordan, if we have a link to, I think we've done more specific ACEs trainings in the past. So many things that you can find around that.
Yeah, I would just say, I know we've done some ACEs webinars in the past. So if you check out our YouTube channel, you can just type in HCT.org into YouTube and go into, I'm assuming they'd be under our adolescent health folder. I'm sure you could find one in there from a previous presenter. Looks like another question came through. If one of you wants to tackle that one.
Yes, that's that. So the question was, with trauma-informed care coming to light for our patients, are there steps being taken for workers to get help when they need? Absolutely. The webinar on March 12th is about all of that. And that is part of trauma-informed care. And honestly, it could be like vicarious trauma. So workers who are experiencing vicariously the trauma could be its own talk.
Yeah, there's also, a lot of these steps and again, you can find some of this on some of our recorded webinars, or we can do more in the future. Well, each of us has a responsibility to take steps to be more trauma-informed in our practice. To become a trauma-informed organization or practice or entity is not something one person can do alone, right? It requires at every level of care, right? From front desk to administration to providers, all the way throughout, right? To the people you might encounter in the parking garage, right? Like across the board understanding. And so that is something that really requires institutional buy-in, and we are looking at, again, other ways to advance that. And this is probably more conversation that we can have in those listening and learning sessions and as we move forward.
Yes, and do look for a vicarious trauma webinar at some point, because probably this calendar year we could make one just for workers themselves.
If there aren't other questions right now, we could take a few minutes to show the trailer for our video series if we want. Is that all right with you, Dr. Conklin?
Absolutely. Sorry, I was trying to figure out how to get it to play.
Oh yeah, and she's got tons of references because she's amazing. So that's all in there as well.
It won't let me play. Should I click on the video, the YouTube video link? This one's not. Or I could unshare my screen and you can
let's
share.
see. There is a link in there that interesting.
Yeah, when we play it.
All right, I can share. Hang on, let me just make things official here. So This project was funded through IPQuick, which we mentioned, as well as the Who's Your Family's First funding that we talked about, to develop a series of training videos around trauma-informed care. We've released 2 of them. The next 2 Mondays, we'll release the final 2. And this is just the trailer to sort of hopefully get you excited. Again, go to that QR code to sign up so that you can have releases, follow us on social media, all of the things. These are freely available to be used by you in any trainings or in any way that you see fit, to make your lives easy and good. And we're so excited to share them with you.
Is it okay if I stop sharing?
Yeah, that's perfect. All right, let's cross our fingers that I can make this work. And we're gonna share screen. Maybe. Here we go. But then let me make sure that it's that audio share sound. Here we go. Oh no, it's in a different screen. Hold
I'm
on.
not making any New Year's resolutions this year.
It's all right. Good news.
and
Now you're
here's
just missing
why.
an ad.
Years ago,
Sorry,
I
friends.
discovered there's a better way to make improvements to your life that's of intentions. But the way we tend to do them can set us up for failure. With BetterHelp, you can pick up therapy and put it down as you need.
Or do you want to make it full screen really quick?
Pardon?
Can you make
I
it
was
full?
just wanna make
Oh,
it full
yes.
screen.
Thank you.
Mhm.
Trauma-informed care is a whole-person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. It's care that seeks to create physical and emotional safety for those who have experienced trauma and rebuild their sense of control and empowerment. In this video, we'll have an opportunity to experience a trauma-informed appointment through the eyes of a patient, starting with the moment they walk through the door.
Good morning. Hi, I'm Bev. Do you have an appointment with us today?
Yeah, I think so.
Great. I am happy to get you checked in. I'm just going to need your first and last name and your date of birth. Now, you're welcome to tell me that, or you can give me a photo ID with that information on it.
Trauma-informed care enhances the patient-provider relationship, communication, and overall patient experience, which can ultimately save time by preventing misunderstandings, reducing patient anxiety, and getting patient buy-in.
Before I even call a patient back, I review their chart. I take note of preferences that are documented, like what they'd like to be called. When we're meeting, my first goal is to create a comfortable atmosphere. I introduce myself with my name and my pronouns, giving them a chance to share theirs if they'd like. I match my pace to theirs as we're moving to the next area. When it's time to take vitals, I explain each step and give as many choices as I can. It's all about fostering communication, sharing control, and respecting their boundaries.
How do we really put trauma-informed care into practice? And why should we do it? It's helpful to listen to stories of actual patients and providers to learn about how significant it can be to experience or not experience trauma-informed care in healthcare.
Seeing myself represented in the spaces I interact with matters deeply. And not just passive acceptance, but active affirmation of all the parts of who I am.
Everyone deserves to feel safe and seen when they're seeking care, no matter what. But for people with a history of trauma, a bad experience can quickly snowball into something larger than just an unfortunate interaction.
Trans people often face indignities, and these are amplified when intersected with race, socioeconomic status, or other factors. One misstep from a provider can elicit a strong response because we're constantly on guard due to who we are.
I've often thought about how my perspective as a male OBGYN has influenced the way I communicate with patients. I don't try to deny that there are aspects of patient-provider interactions that I might not fully understand, but this awareness has pushed me to be more conscious of my language and actions.
Okay, so working in healthcare isn't always easy. Sometimes there are patients or days where it just feels really challenging. Remembering trauma-informed practices, that fundamental switch from what's wrong with you to what happened to you, really does make those times better.
All right.
Thanks, Kara.
That's just a little sizzle of more to come.
Awesome. Well, no other questions have come in, so we can give you 5 minutes back in your day, but I'll give it just a few more seconds just in case anyone has anything. Awesome. Well, keep an eye out for an email from me with this eval, nursing contact hour form, and other information about future events. And thank you all so much for attending today. Really appreciate it. Bye, everybody.
Thank you. Bye.